appreciated so much by the society. But many people use MPA, microscopic polyangiitis, with microscopic pan in the same way. That's okay. Here the term is cutaneous pan involved in arteriole. I told you, arteriole. CNS involvement is called primary CNS vasculitis. Primary CNS vasculitis. And then you can have isolated iotitis. This is called single organ vasculitis. And last one is secondary vasculitis. Secondary to so many conditions. Secondary vasculitis. So many entities are there with us. Before we discuss on this further, I want you to be very clear with the secondary vasculitis causes, which is extremely important for the exam. First one is, what are the CTDs that can produce vasculitis? All the CTDs produce immune complex mediated small vessel vasculitis, as we have discussed. Classically, RA and SLE. Even Jogren and others can also produce. Tough questions are, can you have other components in vasculitis? Yes. RA can produce gangrene due to medium vessel involvement. RA can produce GI vasculitis due to medium vessel involvement. Same way, SLE can produce CNS vasculitis due to CNS involvement and also GI vasculitis. So RA and SLE, although are predominantly immune complex mediated small vessel vasculitis, can have a medium vessel component also. That is very important. Okay, what is the CTD that can produce iotitis? The only CTD that can produce iotitis is IgG4 related disease. Very important. Very important. Drugs producing vasculitis, what are the two categories? Drugs generally produce immune complex mediated vasculitis most often, but sometimes drugs can produce ANCA vasculitis. What are the drugs producing ANCA vasculitis? Asked for the exam. Hydralazine, so many times asked for the exam. PTU is there, minocycline is there, they have not come for the exam. Hydralazine is the one, and levamisole, which is adulterated with cocaine, but levamisole again has not been asked for the exam. Okay, hydralazine, very important. Then what are the infections that can actually have secondary vasculitis? HBV can have a vasculitis which is very similar to PAN. HCV can have a vasculitis which is very similar to cryoglobulinemia. So HBV can have a vasculitis very similar to PAN. HCV can have a vasculitis very similar to cryoglobulinemia. Remember, infective endocarditis is a very important PD for vasculitis. You can get confused between infective endocarditis and vasculitis per se due to so many reasons. Okay, so I think CTD, secondary vasculitis, iotitis, secondary vasculitis, drugs, infection, and lastly malignancy. What are the malignancies producing secondary vasculitis? Mostly lymphoproliferative malignancies. So always keep in mind lymphoproliferative malignancies and their association with secondary vasculitis. So this is the first part of it, the classification. Once the classification is set and done, then the rest of it is actually speaking very easy. Out of this, what is that you must be knowing in detail for the exam? These one-liners, everything you must be knowing. Then, of course, you should be knowing between temporal and Takayasu. This is one very important consideration that you must be having. Then you must be knowing PAN, GPA, MPA, EGPA. So PAN, GPA, MPA, EGPA. This is to be very clear. From pediatrics, you must study Kawasaki disease. The cardinal points in Kawasaki disease that you must be knowing in detail. Okay, this is what you must be knowing in detail. So let us start off with the disease process. So I have been always thinking that this classification is not up to the mark. Who am I to comment on that is a different question. But I have my own views and opinion about each of these classifications. Whatever has been written in the book, I have my own views and opinion on that. So my view is that we have gone in with the size of the vessel as far as apparent heal is concerned. But the disease process still remains a problem, correct? See, the major disease process we are not discussing. We are not talking about why or what is the disease process. So let us try to club the disease with respect to disease process, starting with temporal and Takayasu. So we are going to discuss temporal arteritis and Takayasu arteritis and the important points of difference between the two, keeping in mind the disease process. So what is the disease process in a large vessel vasculitis? If you look at the large vessel vasculitis, the starting point itself is fragmentation of the internal elastic lamina of the vessel. So fragmentation of the internal elastic lamina is the most important thing. That is very important to understand because cranial vessels don't have internal elastic lamina. So that's why cranial vessels are not involved in both these conditions. So fragmentation of internal elastic lamina is there, and then you are having a transmural inflammation. So transmural inflammation involving the media, adventitia, intima, like that, with mononuclear cells. Okay, mononuclear cells and few giant cells. Okay, mononuclear cells, few giant cells, and granulomatous. Sometimes granuloma may be seen, sometimes granuloma may not be seen, but we study it as granulomatous inflammation. Correct. That is why this I forgot to deal. It's a very important pathology question. What are the causes of granuloma with vasculitis? What are the conditions producing granulomatous vasculitis? When you think of granulomatous vasculitis, GPA, EGPA, temporal, Takayasu. These are the four major things that have to come to your mind. Also, RA, Cogan, and CNS vasculitis. So RA, Cogan, CNS vasculitis, GPA, EGPA, temporal, Takayasu. These are the total 7 causes for granulomatous vasculitis. Again, ask for the exam. Besher doesn't have granuloma, PAN doesn't have granuloma, so they will ask you. Microscopic polyangiitis doesn't have granuloma, like that. So this is the complete thing. So that means that this process is the same for both. Whether you take temporal or you take Takayasu, this process doesn't change. Correct? And both are characterized by HLA-DR104. Both are characterized by HLA-DR104. And if you actually look into this, the most interesting part of it is that the pathogen-associated molecular patterns and pattern recognition receptors. There are pattern recognition receptors on the vessel wall. The example is toll-like receptor. Toll-like receptors change for each vessel. That is why in temporal arteries we have one set of vessels getting involved, Takayasu arteries another set of vessels getting involved. But the basic disease process and the basic histology is the same. Basic histology is the same. Knowing that the basic histology is the same, GCA now. GCA is called as temporal arteritis. I'm not happy in calling it as GCA and followed by posterior ciliary artery. These are the 4 vessels. And posterior ciliary artery involvement can produce a very important finding called altitudinal hemianopia. Okay, that has to be kept in mind. Also, the fact that this is associated with anterior ischemic optic neuropathy. Correct. When you talk about temporal arteritis is a disease that you consider only above 50 years. Female-male ratio being 2:1. So you can see it in both, but again more common in females. So you consider it only above 50 years. So when do you consider it above 50 years? I'm telling you median age is 72 years. Although said more than 50 years, it's actually very, very elderly. So the patient can have a typical GCA pattern, okay, or can have an atypical GCA pattern. 75% people are going to come with a typical GCA pattern, 25% people are going to come with the atypical GCA pattern. Atypical GCA pattern is very, very difficult to diagnose. Even for experienced people, they don't diagnose. That's why we are now taught that PO in an elderly person is equal to, you have to be looking out for so many causes. One cause is giant arteries because 25% in presence is PO. 75% are going to come with this classical headache, new onset, boring type of headache. Very important to see that it is a new onset headache, moderate severity. Few people may have vessel changes like thickening, nodularity, absence of pulse, but again, that is not seen in all the patients. What you can always look for is increase in ESR. Any elderly person with a new onset headache with an increase in ESR and a very specific symptom called jaw claudication. So any new onset headache with an increase in ESR, with a jaw claudication, etc., you can always think of GCA. And any PO atypical presentation which is seen above 50 years, 60 years, etc., again you can think of GCA. These are the two patterns. I would like you to keep in mind that investigation of choice is a temporal artery biopsy. But you know the temporal artery biopsy can be done only by the neurosurgeon, so you need to call him and then get it done. So with the wasting time, we can go for the Doppler ultrasound. Doppler ultrasound is actually speaking very much like 70%, 80% sensitivity specificity is there, so it's fine. But still for the exam, it is temporal artery biopsy. Skip lesions can be seen. So again, if you're very confident, you can go for repeat biopsy, even if the first biopsy is abnormal. But the fact is that whenever you suspect this, first biopsy is normal, you can go for another biopsy. Suspect this, you have to start the patient on steroid. The reason being that, very, very important reason being that otherwise there can be a loss of vision, which can be unilateral, bilateral, temporary or permanent. Generally, visual losses are unilateral and reversible, temporary, but you can't say that way. So giving steroid is very, very important even when you suspect the diagnosis. The other thing is that so many of the people have associated polymyalgia rheumatica. So polymyalgia rheumatica goes hand in hand with GCA. That's another thing that you have to keep in mind. What is polymyalgia rheumatica? Elderly person who has pain and stiffness of the hip to shoulder pelvic girdle. Okay, hip to shoulder and pelvic girdle. I wouldn't call it as an arthritis, I call it more as a myositis rather than arthritis because it is more myositis that we see there. Myalgia is what we see there. But an ESR increase more than 50 and you are having brilliant response to low dose steroids. You are having brilliant response to low dose steroids. That's why there is no problem. Diagnose PCA and miss PMR, there is no problem because you're already giving steroid. If you diagnose PMR and miss PCA, the problem is you're giving low dose steroid. That's of no value in GCA. You need high dose steroid in GCA. High dose means 1 mg per kg dose per day dose is required. Okay, so that is it. Age at onset more than 50. New headache, temporal artery abnormality, elevated ESR, abnormal artery valves. Now, whenever you study GCA, so typical GCA has headache, jaw claudication, visual symptoms, PMR. Okay, fever, fatigue, weight loss, malaise, any one of this would have been experienced, but all that comes under atypical GCA. And as far as atypical GCA is concerned, PO is the one. In the textbook says C5 radiculopathy and throat pain and cough and all that, but this is due to lingual artery involvement, this is due to radicular involvement, etc. But that's all very rare. When you think of atypical GCA, only question possible for you is PO. 30% of people can have aorta involvement in this. 30% can have aorta. That is why higher order point, always when you diagnose GCA, do take a PET scan to rule out aortitis. And late stages, the patient can have thoracic aneurysms. That is all late and not ask for the exam. Don't think that aorta is not involved because many people think that aorta is involved in TACA, so not involved in GCA. Don't think like that. 30% can have aortitis, late stage those for thoracic aneurysms. And that's when GCA is mandated to take a PET scan. Okay, GCA responds very well to steroid, but a tapering dose of steroid, there have been relapses. That time we are trying to actually think of treating with interleukin-6 inhibitor, that is tocilizumab. So tocilizumab is also coming up in a big way in GCA. Okay, now this whole point about how you compare GCA with Takayasu, now that's a very, very important discussion. Now comparing GCA with Takayasu, extremely important discussion. Let us see how to actually go about with this. So very important part for discussion is to compare GCA with Takayasu. Let us draw the comparisons. I think that should be more than enough. Why are we comparing GCA with Takayasu? The first instance itself is because both are having the same histology, same disease process, and I told you the disease process. Let us see the points of difference. Takayasu is seen only under 40 years with a female-male ratio of 9:1. Median age is 25 years. So that's the first major difference. So the age group is totally different. Second point I told you, the toll-like receptors seen on the vessels are different here. Because the toll-like receptors seen on the vessels, number and all you need to know, are different. The vessels category are actually going to be very different. That's why the most common vessel involved is the left subclavian artery. Left subclavian is the most common vessel involved. Then we are having the aorta involvement. Left subclavian artery is there. Then aorta involvement is there. Mesenteric arteries can be involved. Coronary arteries can be involved. So these are things which are generally very, very uncommon in a giant cell arteries. Two things which are extraordinarily important is renal involvement and pulmonary involvement. Renal and pulmonary involvement per se to get in rheumatology itself is very uncommon. Renal artery is getting involved only in two conditions in rheumatology. One is Takayasu and the other one is SPAN. Pulmonary artery is getting involved again only in two conditions in rheumatology. One is Takayasu and the other is Beshet. So because of its renal and pulmonary involvement is very important. Mesenteric and coronary involvement may be there. Aorta is there. Most common is the left subclavian. So because the most common is the left subclavian, we have to think of upper limb claudication as the most important symptom. So there it is headache as the most common symptom. Here it is upper limb claudication. As soon as you actually see the upper limb claudication, look for the asymmetry in pulse and also look for the asymmetry in BP and look for the carotid or the aortic bruit. You can get the bruit, carotid, aortic or subclavian. So whenever you are having claudication, that is the most important. Young girl having anything with respect to difficulty in carrying activities with respect to the upper limb, that is taking something from the shelf or putting the hook of her blouse or actually lifting a weight from above, bringing it down. So any kind of this or washing clothes. So any of this can actually have extreme pain. You have to look for pulse and BP, asymmetry in pulse and BP, carotid or aortic bruit, that's it. And CT angiogram is the investigational choice. CT angiogram is the investigational choice. And again, we use steroids here, but many times associated with surgical requirement, like renal artery, we may have to do a plasty. So it's not surgical, it's the cardiologist who does it, but still some kind of a surgical investment, intervention may be required. So when you try to compare this with temporal, you understand that although the disease process is the same, the patterns are totally different. And disease process and patterns that you have to keep in mind. The possible clinical questions are headache in an elderly person. Second possible clinical question is headache, visual disturbance in an elderly person. Third possible question is PO in an elderly person. Fourth is upper limb claudication in a young girl. These are the four clinical scenarios that can be clubbed with this. And also a question can come on renovascular hypertension, where in a young person in India we have to think mostly about Takayasu. Outside it is FMD, but whenever we have RVH in a young person in our country, especially female, we are thinking in terms of Takayasu. So that is the first part of our discussion. The second part of our discussion is going to focus on the small vessel vasculitis. So large I told you. So once again to show you this, see proximal occlusion bilateral. What is the gold standard? Arteriography is the gold standard. And nobody is going to do that, okay? Because we are obviously happy with the CT or the MR angio. So CT angiogram, if MR angiogram is there, okay, well and good, both are considered to be equal. That's how we look at it. So CT and MR angio are almost equal, but if somebody is asking you best, then I think you can say MR angio, but there is no much of a difference. Surgical revascularization has to be done in our patients, especially with renal involvement to do percutaneous transluminal renal angioplasty and all that. Sometimes tending also may be good. Okay, so I think that part is done. So first question is trying to compare between temporal and Takayasu under the large category. The second major question that you get is a comparison between the different ANCA vasculitis and then later to compare it to PAN. So let us just try to compare this anti-neutrophil cytoplasmic antibody vasculitis or what we call as ANCA vasculitis. So this ANCA is basically, there are so many things in that. Pathogenesis part is not required for you at a serious level. Whatever that is most pertinent we have discussed in the video, the pathogenesis part. The ANCA vasculitis is basically a set of antibodies against your proteinase 3 or against myeloperoxidase. So proteinase 3 or against myeloperoxidase, which are present in the granules of the neutrophil. Okay, they are present inside the granules of the neutrophil. And in a primed neutrophil, they actually come to the surface and then there are antibodies against them. So when you do a study for ANCA, the screening test actually you do here is the indirect immunofluorescence, just to identify the pattern. This is in contrast to ANA, where screening is not by this, confirmation is by indirect immunofluorescence. There is no screening there, there is only indirect immunofluorescence. Here, confirmatory test is actually speaking ELISA. So ELISA, right? This is how we do this. So screening test is IIF, means we have two patterns on the screening test. One, we can get a cytoplasmic pattern, or we can get a perinuclear pattern. So two patterns can be seen in this. One is called cytoplasmic pattern, the other one is called perinuclear pattern. This is how the cytoplasmic pattern looks like. This is how the perinuclear pattern looks like. It's actually speaking very to identify that your level may not be possible. If you see the neutrophil lobes, right, then it's mostly equal to a cytoplasmic pattern. If you see it as a round, it's a perinuclear pattern. Anyway, so cytoplasmic pattern means that you can have, it is not to be confirmed with an ELISA because you know that it is always cytoplasmic pattern is going to be a true positive. So if you want, you can confirm where you see antibody against the proteinase 3 by ELISA. So when you see actually antibody against the proteinase 3 by ELISA, then you know that yes, this is cytoplasmic pattern. But even otherwise also there is no false positive and all. It is cytoplasmic pattern, it's mostly against proteinase 3. What are the causes of a cytoplasmic pattern? Cytoplasmic pattern can be seen in GPA in around 70 to 75% of patients you'll be seeing. You can see this in renal limited vasculitis. You can see this in MPA And you can see this in EGPA. So you can see this in different numbers. MPA, you can see it in around 40%. EGPA, you can see it in around 5%. And renal limited vasculitis, you can see it in around 20%. So these are the actual numbers. But GPA 70% very, very important. MPA 40% very, very important. This you have to be known. Okay, so only these many causes are there. But whenever you get a perinuclear pattern, they need can be due to antibody against myeloperoxidase, that is one chance, and it can be due to some other antibody where the antibody against myeloperoxidase test is negative. So whenever the antibody is myeloperoxidase, then we call it as true p-ANCA positivity. Whenever it is negative, we call it as false p-ANCA positive. So we are having c-ANCA positive means it's always true p-ANCA and false p-ANCA. True p-ANCA means myeloperoxidase is the antigen. False p-ANCA means myeloperoxidase is not the antigen. When you're looking for true p-ANCA positivity, these are the common things associated with true p-ANCA positivity. First will be again MPA, renal limited vasculitis, then EGPA, and then of course the last one, that is GPA. So EGPA, last one is GPA. You see renal limited vasculitis, 70% of the people are p-ANCA positive. Very, very important. Microscopic polyangiitis, 50% are p-ANCA positive. EGPA, 40% are actually speaking p-ANCA positive, and in GPA, 25% are p-ANCA positive. Exact numbers you need not know. What you have to know is that maximally it is a renal limited vasculitis. So c-ANCA was maximally in Wegener or GPA, p-ANCA is maximally in renal limited vasculitis. Apart from this, drugs and also Goodpasture syndrome. These are the other causes for true p-ANCA positivity. So true p-ANCA positivity is seen in ANCA vasculitis, of which renal limited vasculitis is very, very important. Drugs are very, very important. Goodpasture. Drugs means hydroxyzine is single most important. I also told you PTO, minocycline, levamis, or altric, cocaine, I told you, but single most important inside that is hydroxyzine. Okay, false p-ANCA positivity. False p-ANCA positivity can be seen in all these conditions. Very, very, very important. False p-ANCA positive can be seen in all these conditions, of which autoimmune hepatitis has been asked for the exam. It is type 1 autoimmune hepatitis, primary sclerosing cholangitis has been asked for the exam, RA, IBD, infective endocarditis, cystic fibrosis. Cystic fibrosis also has been asked for the exam. They are all conditions where we get a false p-ANCA positivity. So very, very clear. What are the conditions with the true p-ANCA positivity? What are the conditions with the false p-ANCA positivity? And remember, true p-ANCA positivity maximally is in GPA. For true p-ANCA positivity is maximally seen in renal limited vasculitis. Two very important questions. False p-ANCA positivity is seen with a whole lot of conditions, of which autoimmune hepatitis, never forget, primary sclerosing cholangitis, never forget, cystic fibrosis, never forget. Okay, right. Now we are actually trying to draw comparison between them. How will you draw comparison between them? Starting with GPA and NPA, and then trying to include EGPA into the list. But pathogenesis wise, GPA and NPA are going. EGPA is a little different, so that's why we are actually looking at this. What is the common binding point here? Common one binding point is ANCA. Already C-ANCA and P-ANCA difference is there, but common one binding point is ANCA. GPA has C-ANCA in 70% and P-ANCA in 25%. Whereas NPA has C-ANCA in 40% and P-ANCA in 50%. Just to remember that P-ANCA is more common in NPA, C-ANCA is more common in GPA. So ANCA is one side. ANCA also means that it is post-immune, which means if you do an immunofluorescence, that will be negative. Correct? Now, what is the kind of vasculitis? It is going to be a necrotizing small vessel vasculitis. Very, very important. Necrotizing small vessel vasculitis is what you are going to see with fibrinoid necrosis. So fibrinoid necrosis, necrotizing small vessel vasculitis. The word is very, very important. In immune complex mediated vasculitis, it is going to be leukocytoplastic vasculitis. Here it is going to be necrotizing small vessel vasculitis. Correct? The main difference is here you will see granuloma. Here you will see granuloma. So GPA there will be a granuloma, there will be no granuloma. Okay, both the diseases are seen above 40 years. There is nothing much of a sex predilection to talk about per se, but MPA they see is slightly more elderly. GPA is maybe 40 to 55, 60. This is 50 to 65, 70, like that. Okay, right. EGPA on the other hand, instead of this necrotizing vasculitis neutrophils, here you are having full eosinophils. Okay, and fibrinous necrosis may be seen. But the point is, instead of neutrophil, you are having eosinophil, and extravascularly you can see granuloma. So extravascular granuloma is there. I told you the 7 conditions producing granuloma: temporal Takayasu, GPA, EGPA, rheumatoid vasculitis, Cogan syndrome, primary CNS vasculitis. These are the conditions where you can get a granuloma. Okay, so this essential point of understanding is clear. Eosinophilic granulomatous polyangiitis has an asthmatic phase, and then they go to the vasculitic phase. So that's why it starts a little early, and it is confused with asthma in the beginning, and then only it has a proper vasculitic phase. Both these diseases are predominantly small vessel vasculitis. They generally don't involve the other vessels. But eosinophilia and EGPA EGPA has a tendency to also involve the medium vessel. So that's another big point of difference. EGPA has a tendency to involve the medium vessel. Correct. So this much is clear. Let us go to the individual vasculitis, starting with GPA. In GPA, there are 3 major manifestations: 95%, 90%, 60%. So 3 major manifestations: 95, 90, 60. 95 is upper respiratory tract, 90 is lower respiratory tract, and is kidney, that is 60%. Okay, upper respiratory tract manifestations can be either sinusitis due to Staph aureus, sensory neural hearing loss, can be subglottic stenosis, can be so sensory neural hearing loss, sinusitis, subglottic stenosis, or serous otitis media. Correct, serous otitis media. Or can be a midline nasal deformity. So all these things are possible. So midline nasal deformity, sinusitis, sensory neural hearing loss, all these things are so very classical. Remember that MPA can have upper respiratory tract involvement in 30%. EGPA can have allergic manifestations in the upper respiratory tract, like allergic bronchitis, allergic sinusitis, rhinitis, etc. But generally, so much of upper respiratory tract manifestation is not seen anywhere else. That's why midline nasal deformity, subglottic stenosis, SNHL, serous otitis media. If you get questions for the exam, please think it is always equal to GPA. But very important. Point is that in GPA, we don't have any constitutional symptoms, correct? Whereas in NPA, we get a lot of constitutional symptoms. That is very important. And in EGPA, we don't get any constitutional symptoms. So constitutional symptoms are very, very prominent in NPA, not in GPA. Then comes lower respiratory tract in 90%. So there can be 2 things here. One, you can have nodules which cavitate. Thick-walled cavitating nodules is what we call it. Or diffuse alveolar hemorrhage. 2 things are possible. Whereas in microscopic polyangiitis, only DH is possible. Thick-walled cavitating nodule is not there. Only DH is possible. And in EGPA, nothing of this kind. You can have fleeting lung infiltrates. That's why they tend to confuse you present like asthma and all. No? They have no DH, they have no nodules, cavity, nothing like that. So nodules and cavity, thick-walled cavity, GPA, DH, NPA, and nothing in EGPA. It's more asthma-like presentation. Kidney 60% has RPGN. Which RPGN? RPGN type 3. In MPA, also RPGN type 3, but very, very important, RPGN type 3 seen in 100% patients with MPA, 60% only in regular, 100% in MPA, and non-severe renal manifestations. No severe, nothing big. RPGN, etc. in EGV, I have not even seen a single case. I don't think anybody has seen. So it's like very mild to see and very mild also, if at all there is renal involvement. These are the 3 major manifestations. And you know how to compare. Then we go to the minor manifestations, starting with ocular, then coming to skin, and then neurological. GPA ocular manifestation is scleritis. Okay, GPA ocular manifestation is scleritis. When you look at MPA and when you look at EGPA, there is nothing ocular that you need to study with respect to this. So nothing ocular we need to study with respect to this. Skin involvement in a small vessel vasculitis goes without saying, and skin involvement is okay here, but it's very, very, very significant in MPA. MPA has got the maximum skin lesions, and the most classical skin lesion of a small vessel vasculitis is purpura. Here also it may be seen, but it can involve medium vessels. So please be careful about that. Medium vessels may be involved. In that case, ulcer and gangrene, you may get. Neuropathy is seen in GPA. Neuropathy is very, very prominent in EGPA and only mild in MPA. So neuropathy is very, very prominent in EGPA. Asthmatic presentation with neuropathy manifestation. So classical here, you can get even cranial neuropathy. You can have medium vessel like mononeuritis multiplex. Any kind of neuropathy can be seen in EGPA. So when you think of EGPA itself, it is neuropathy that is most important. Okay, but EGPA, because of this eosinophil issue, can have something called eosinophilic gastroenteritis, can have eosinophilic myocarditis, and that eosinophilic myocarditis can be very, very dangerous and is often thought of as the most common cause of death. So eosinophilic gastroenteritis, eosinophilic myocarditis, of which eosinophilic myocarditis is very, very most cause of death. That's how we compare everything. Okay, I think this comparison, everything is perfect now. Now I want you to actually think about what you do in anti-vasculitis. In the anti-vasculitis, again, it is steroid that is a mainstay of therapy with cyclophosphamide, oral or IV here. Okay, oral or IV, cyclophosphamide is the basic induction regime. The other option instead of cyclophosphamide is rituximab. So either you can keep rituximab as a reserve and then relapse, or upfront itself you can use rituximab. Nothing wrong with that. And once you go into the maintenance phase, it is azathioprine that is preferred here, not MMF. Aza is better than MMF. In a SLE, MMF is better than Aza. Here, Aza is better than MMF. So this is the basic treatment option that we have for ANCA-associated vasculitis. For Church-Strauss EGPA, interleukin 5 antagonist called mepolizumab has made a lot of changes with respect to treatment. I'm not going to the details because the same ANCA-vasculitis, the regime of steroid cyclophosphamide was tried in EGPA but was not associated with good results. Now they are not giving cyclophosphamide rituximab in EGPA and giving mepolizumab directly, and mepolizumab is found to be very, very useful in EGPA. You can see a lot of studies on that. I'm not going there. Okay, so I think that part is very, very clear. Now we are actually going to compare this with PAN, polyarteritis nodosa. So let us try to compare this with PAN. What is PAN? PAN is a focal necrotizing inflammation. So focal necrotizing inflammation is what is PAN. Do you have any granuloma in PAN? There is no granuloma in PAN. Do you have any antibody in PAN? There is no antibody in PAN. So antibody means ANCA. ANCA, everything is negative. There is no granuloma. There is a patchy necrotizing inflammation. That is what we call as PAN. When you try to compare PAN with these two diseases, the first thing that has to come to your mind is PAN has an associated hepatitis B positivity. So that is very important, what is called the famous 30:1 ratio. 30% patients with PAN have hepatitis B, but only 1% of patients with hepatitis B have PAN. That's how you study that. And also hairy cell leukemia, another important association that you have to keep in mind with respect to PAN. The opening sentence on any book with respect to PAN is that PAN will have lots of constitutional symptoms like NPA, constitutional symptoms like weight loss and all, very classical of PAN. And also the fact that PAN will never involve the lung, will never involve the kidney. This you have to be very careful with. Because when I say PAN is not going to involve the lung, I mean lung parenchyma is not involved. But PAN can involve the bronchial artery. Because of bronchial artery involvement, you can have hemoptysis, nothing wrong. Same way, PAN is not involved in the kidney, means glomerular disease is not seen in PAN. But that does not mean that renal artery cannot be involved. Renal artery can be involved in PAN, and renal vascular hypertension is seen in PAN. PAN and ACAS are the two conditions where you will see that. Okay, same way, microaneurysms. Microaneurysms are part and parcel of which disease means it is PAN. Everywhere else it is stenosis, here it is microaneurysms. Because of microaneurysms, we need MR angiography to figure out PAN. Conventional CT angiogram may not be enough in the case of PAN. Okay, so I think this much is very, very clear. Once this much is clear, let us try to look into the specific points with respect to PAN. Specific points with respect to PAN is the medium vessel involvement, correct? So the medium vessel involvement in PAN itself means that you are going to get all these findings. What are the findings? Nodules, ulcers, gangrene, mononeuritis multiplex, all these features which are classical medium vessel findings. Okay, petechiae, purpura, bulla, urticaria, they are all small vessels. This is medium vessels. Nodule, ulcers, gangrene, that is the medium vessel 1. Renovascular hypertension. Okay, that's the reason why you have significant secondary hypertension here, like in Takasu. So renovascular hypertension, always keep in mind. Okay, but again keeping in mind that lung parenchyma and renal parenchyma are always spared. Lung parenchyma, renal parenchyma are always spared. And small vessel skin lesions like purpura, petechiae, all these are not seen. You have nodules, ulcers, gangrene, and those things. Okay, so I think this pattern of involvement is also very, very clear. And sometimes you may be having testicular artery involvement. So testicular artery involvement may be seen. Okay, so this is in some total what is PAN. And PAN, we don't have a specific treatment guideline. We just treat like ANCA-associated vasculitis, but in general, the prognosis in PAN is very, very poor. So when you try to compare everything together, pulmonary infiltrates or nodules, vagus both can be there. Microscopic cholangitis, only DH can be there. Lung parenchyma not involved here. Lung infiltrates can be seen in Church-Strauss. Alveolar hemorrhage, vagus possible. Microscopic cholangitis possible. PAN not possible. Church-Strauss syndrome, you can say not possible. Glomerular hemorrhage, vagus, microscopic cholangitis not seen here. Very, very mild in Church-Strauss. Upper airway disease, vaginal. Skin lesion, microscopic PAN. Peripheral neuropathy, more with Church-Strauss. CNS involvement again because of polyneuritis cranial cells. Multiple cranial involvement again is more common with Church-Strauss. Okay, so thus we have tried to bring ANCA-associated vasculitis with this again to show you DH. Okay, and I have discussed the clinical possibilities also. Just trying to keep this in mind. Weight loss more than 4 kg, PAN yes, because PAN has constitutional symptoms. Testicular yes, mononeurotrophic polyneuropathy, hypertension, hepatitis B, small vessel containing neutrophil, focal involvement. Everything we have discussed. One thing I forgot to tell you was libido reticularis. Yes, mononeuritis multiplex, libido reticularis, nodules, ulcers, gangrene. These are the classical features of a medium vessel vasculitis. All this can be seen in PAN. Right, so we have actually done a complete, we have looked into all these things together. Okay, so we go to the last part of our comparison, that is to compare between the important entities inside immune complex mediated vasculitis. So immune complex mediated small vessel vasculitis. So when you say immune complex mediated small vessel vasculitis, there is a problem. The problem is, as per the current classification, we have IgA vasculitis inside that, which is called as Kenosha-Online purpura, now called IgA vasculitis. Then we have cryoglobulinemia associated vasculitis inside that, but first I'm not bringing into discussion whatsoever. Then we have hypercomplicated urticarial vasculitis inside that. These are the three entities. And I told you in HUV, you have to just remember this antibody called anti-C1q antibody, nothing else. So that also I am removing for the time being. Under single organ vasculitis, we have discussed hypersensitivity vasculitis, cutaneous leukocytoclastic angioitis. That also has some immune complex mediated pathology. So if you want to add that also, you can add that. Otherwise, for all practical purposes for our exam, these are the two entities that we should be knowing and we should be comparing also as far as the exam goes. What is the common histology finding? Small vessels. There is no fibrinous necrosis, there is no necrotizing vasculitis. We are actually having what is called leukocytoclastic vasculitis. That means fragmented nuclear debris. Leukocytoclastic vasculitis is the word that you have to be remembering, with no ANCA positivity. So no ANCA positivity, leukocytoclastic vasculitis with immune complexes seen under the fluorescence microscope. So immune complexes are going to be present, ANCA is going to be absent, and you are going to see leukocytoclastic vasculitis. There it was fibrinoid necrosis with neutrophilic infiltration. That's the most important thing. So necrotizing inflammation means neutrophilic infiltration with fibrinoid necrosis. Here that is not the way. It is fragmented neutrophilic debris that you actually see here. So inside this, the most common entity is IgA, and we are having to compare IgA vasculitis with cryoglobulinemia. So this is what we are actually going to do here. Okay, IgA vasculitis is seen predominantly in children under 5 years. Okay, this is where you see, and they are mostly boys. But when it comes to cryoglobulinemia is mostly seen in the middle to late middle age females. Okay, so it's little different, right? So that way it is a little different. Can you have an adult component in IgA vasculitis? Yes, adult component may be there. They have a more severe renal involvement. So adult component may be there. They have a more severe renal involvement. Let us try to look into the points here. So IgA vasculitis, skin can get involved. Then renal involvement can be there. GIT involvement can be there. Joint involvement can be there. So these are the 4 things that we are going to discuss. First and foremost, skin, because skin is seen in every single person. So it's like 100% of the people are actually going to have skin involvement. What is this 100% people going to have? They are going to have non-thrombocytopenic palpable purpura in the lower limb. That's what you are going to get, and it is going to be predominantly composed of IgA. Okay, so that's the skin manifestation. If you look at cryoglobulinemia also, you will get the same purpura, but it is called as the confluent purpura. Okay, it is called as the confluent purpura of cryoglobulinemia. Nothing much of a difference. Second is GIT involvement, which is seen in around 50% people. GIT involvement is seen in around 50% people. Here you have mostly what we call as the abdominal angina. Many of these people have what we call as the abdominal angina because of the severe acute abdominal pain. The dangerous complication that you have to suspect is intersusception. Intersusception may be seen. That is a dangerous complication. Sometimes you may see testicular torsion. Testicular torsion may be seen. Testicular artery may be involved in PAN as well as in HSP. Then sometimes you may see just the scrotal swelling. Sometimes you may see blood in stool also. So blood in stool may be seen, scrotal swelling may be seen, testicular torsion may be seen. Dangerous complication, intersusception. Most common complication is abdominal pain or abdominal angina. When you think of GIT here, it is the association with HCV that has to come to your mind. HCV association is extremely important because cryoglobulinemia is divided into type 1 cryoglobulinemia, types 2 and 3 cryoglobulinemia, because cryoglobulins are cold precipitated immunoglobulins. Type 2 and 3 cryoglobulinemia is what is HCV positive. That's what we are interested in. It is rheumatoid factor also positive. So HCV positive, rheumatoid factor positive. And this type 3 is completely polyclonal. Type 2 is actually speaking monoclonal IgM and polyclonal IgG. So 2 is monoclonal IgM, polyclonal IgG. 3 is completely polyclonal. And type 1 is completely monoclonal. It is monoclonal IgM there. Because it is monoclonal IgM, type 1 is dealt by the hematologist because it is many times associated with Waldenstrom's macroglobulinemia. We are dealing with types 2 and 3, which is seen with HCV and Sjogren, and HCV is going hand in hand with Sjogren. And 2 is monoclonal IgM, polyclonal IgG. 3 is actually speaking polyclonal IgG. So that is what it is, and 2 and 3 are positive. So 1 is dealt by the hematologist, 2 and 3 are dealt by the rheumatologist. So that is the GIT part. Joint part, when you actually see with respect to our arthritis part, which we see with respect to IgA, it is called as the KLMNO arthritis. Okay, KLMNO arthritis. What is the meaning of KLMNO arthritis? Knee joint predominant, large joint, migratory, non-deforming oligoarthritis. So knee joint predominant, large joint, migratory, non-deforming oligoarthritis. This is called the KLMNO arthritis that you see in HSP. Okay, here you are having a SLE-like arthritis. So SLE-like arthritis, I told you everything about that. And associated, you can have myalgia also. So SLE-like arthritis associated, you can have myalgia. Renal here is going to be definitely IgA nephropathy, but mostly it is going to be a self-limiting form of IgA nephropathy. And here renal is going to be MPGN. Renal is going to be MPGN. When we studied classical MPGN itself, the most important cause we studied was cryoglobulinemia. Okay, so I think I have made a very reasonable discussion. Skin, I have told you. Renal, I have told you. GIT, I have told you. Joint, I have told you. Correct? Skin is all about this classical non-thrombocytopenic palpable purpura, which you see in the lower limbs. Here, only one word additional you have to remember is confluent purpura in cryo. Renal is IgA here, self-limiting. Here it is classical MPGN. GIT, what you have to think of here is mostly the abdominal angina. Here, what should you think of? Here you must be thinking of HCV associated. Joint should be KLMNO arthritis. Here it should be SLE-like arthritis with also arthralgia, myalgia. Okay, fine. And here treatment is also giving steroid for what manifestation? For joint manifestation and GIT manifestation. Skin and renal, it doesn't work. And even if you give steroid, don't give steroid also, nothing much will happen. The disease will go into remission. But it will relapse later on, but it's got a very good prognosis, except adult. Because adult, what can happen is they can have a IgA nephropathy going in for RPG and resolution. So adult means IgA nephropathy can go for RPG and resolution. That is why it is bad. Otherwise, it's fine. Here you are trying to treat